latecomers, welcome. Until that is settled. So, apart from multiple doctors, delay in diagnosis, all those things that you know, my presentation is going to be about accurate diagnosis and visual precision, how we could increase that. I hope presentation. In general, there's readmissions, recurrence of pain, readmission, and repeat surgeries. And it is about 1/3, it could go up to 1/3 of all endo patients. There's one Canadian study here in these slides. The first slide probably going to say 4-year follow-up of 6,000 patients who are diagnosed with endometriosis, almost 30% reoperated, 10% of them hysterectomy. And so then Vercellini studies from 2006, we failed mostly on the early disease treatment. Is this improper surgical technique or incomplete surgery? Maybe both. Probably both. We consider in our foundation the proper surgery of endometriosis is not burning, not ablation, excision. And the word excision is really stolen from breast cancer concept. The tumor has to be, the borders have to be free. That's how we relate to it. In incomplete surgery, maybe we are not recognizing the disease enough. We're missing. And one of the things we may be missing is probably disease does not come in usually in color format. The disease is something else. We know for years, 50 years, it's all black blueberry and then red wine and obviously Dr. what's his name? It's right here, Martin. Martin in 80s brought the concept of atypical endometriosis. We started to recognize non-colored lesions. This is Vercellini's study. As you see, the black line is stage 1 disease. They are coming with symptoms more than the advanced disease. So when you look at the slide, again, the black, very obvious, the white, very obvious. There are more things happening. Look at the brown areas where the capillaries almost get lost. You see the discoloration there. Those are the areas I want to pay attention for you, and I'm going to show you some pictures. So the treatment really starts with doctors. Success of the treatment starts the visual recognition of the disease. In endosurgery, it's very easy to lose the good visualization, because for maybe 30 years, maybe all throughout laparoscopic technique, the overpowering of light is our biggest enemy, maybe, because it absorbs, it shines, and you get tired and long surgeries. So there has been filters and everything, but it hasn't been really much practical. This is a very simple technique that I will show you. So, but with numbers, I can tell you this. We just presented this in AAGL, but I compared cul-de-sac and pelvic sidewall. There were 775 specimens we excised in 2014 in 115 patients. Advanced endometriosis, advanced endometriosis, which is endometrioma and deep DIA, were excluded. Only peritoneal endometriosis, we looked at it. So this technique is very simple. Methylene blue dye and submersion, hydropilotation, almost near contact, my residents know, and then retroperitoneal hydrodistension with blue dye, completely eliminating the subperitoneal muscle and redness reflection that comes to peritoneum. So we looked at it, this out of 775, 663 specimen versus 112 specimen, almost 5 times as much, 6 times as much specimen were removed from the pelvic sidewall. So all of a sudden you can tell we have increase in specimens on the sidewalls. So if you have 2 sidewalls, it's, again, 3 times it reflects to each side. So that's the percentages. So we look at the numbers. of the histological findings on these specimen, only 407 are, which is 53% is typical endo. 6% is stromal. Look at the inflammation. How much inflammation there is? 31, defined by the pathologist, and fibrosis. When we look at the cul-de-sac, only cul-de-sac removal without any ABC, we have 112 specimens. Typical is 58 to 39, 13. Look how little stromal endometriosis is there without an ABC. When we look at the sidewall, suddenly the number is obviously increased, 663 on the sidewall, we're excluding the pure cul-de-sac. So look at how many stromal endometriosis, 47. Inflammation, 198, and typical, 349. So when we compare, we have significant number of specimens removed from the sidewalls, but more important, it's statistically significant, there is almost 20 times more cul-de-sac specimen, stromal endometriosis removed with the using of this dye technique. So simple, methylene blue in 3 liters of linear lactate, it has to be warm. And your ovaries are suspended with grainy needle. My residents know how I do that. So basically, submerged hydroflotation. You see wonderful pictures under the water. Look at these vessel formations. I mean, they're fantastic. But what happens is, this is just a contrast. It's really nice to recognize these vessels during the cases. My scope is almost 1 centimeter, less than 1 centimeter closer to these lesions. So, I hope it did not, okay. So what does this, what happens is, with this elimination of gas pressure, obviously, elimination of large diffraction, red and yellow spectrum of light is gone. So this is an example, these flattened lesions with gas pressure and how they float. You see it there. Look at this. This is the earliest lesion. I showed this yesterday. Look at this nipple-like popping out, angiogenesis, budding, and these floating lesions under. You see these little grape-like buddings are visible. These are all early endometriosis, right? So as we move, I'm going to show you more pictures for you. How's the time? Okay. This is a patient that is reoperated. This is an area excised before. People say endo doesn't come back really, but it does come back. And it comes back in the excised area, within the center of excised area too. It doesn't really come at the edges. Those are incomplete removal. You see these lesions? So underwater, you see some of these lesions are floating. This is the floating one. There's one that's not floating. Two type of lesions. I excised this very carefully, went to pathology. When I go to pathology, pathologists run away from me because I don't let them go until I get my answer. So they did make a cut for me. This is the floating lesion. You see this stroma. This showed this floating region up here on the top. You saw it, and this is the stroma positive. No, there's no gland, only stroma. We do CD10 and it's 100. That's the way it showed, pure stroma. And the flattened lesion showed gland. This is the flattened lesion, gland with stroma. So even at the earliest phase, we could catch these lesions. So that's how we do the hydrodistension. I'm going to come to this. So, okay. So basically, when you look at it, you see one lesion up there and a little bit more maybe white areas, right? you don't see it. There's one lesion there. When you do the hydrodistension, let's see how this is gonna. So we make it, ovaries are suspended, basic irrigation fluid, under pressure, you distend this. Now, let's look at this very carefully. What happened here is, all of a sudden, the white lesions are more prominently there, but around the white lesions, you're gonna see multiple peritoneal defect. Like we sometimes call this leopard sign in some cases, but you see how the central lesion have contracted the other part of the peritoneum. So, normal peritoneum, very shiny, almost transparent, very good texture, there's nothing smooth. And it's CD10 negative. The peritoneum that is visible more with the elimination of background redness is defective. Texture is gone. You see almost holes there. And these are CD10 positive. This is an actual pathology slide of the same patient that you see there, with macrophages, eosinophil, digestive, all inflammation, stroma and inflammation, the same patient. This is a very interesting patient. So there's recent excitement about newborn endometriosis, the newborn vaginal bleeding, newborn retrograde period versus embryological, whatever that is. This patient is not a newborn. Acute abdomen, emergency room patient, operated on Lennoxville last year, maybe one of the residents could be there. Hemoperitoneum, there's no source of blood. The patient is 62 years old in menopause for the last 10 years. Hollywood lady on massive dose ERT and bioidenticals, massive. And this is how her peritoneum looked. Just not much. After you suck the blood, you look everywhere. This is how it looked with the retrograde, how thickened. This peritoneum was thickened like a leather, almost. We take this peritoneum, put it on a foam. I go to pathology. We do our cuttings. When we do cutting, this is how it is. We pin it on a form, and we slice it like this, right? We look at the same specimen that you saw. You see the gland, nicely, stroma, beautiful stroma, and some inflammation around it. Trichrome staining, smooth muscle. Then we go to the area that there's no gland. This thickening, we look at that too. In the same woman exposed to estrogen for 10 years, hyperdose. You see blood vessel, significant nerves, and primitive smooth muscles all over. And we look at the mesothelium, and specifically stained with calretinin, very thickened mesothelium, very thickened submesothelial layer with nerves, perineural inflammatory cells. And guess what? The thickened mesothelium is positive for estrogen. So that tells you the element of stem cells or wound healing does bring estrogen positive cells there. These are the cells most likely become the stroma. So this is the end of my presentation. I hope you will retain something maybe you can use in your practice. You see how you can benefit. Thank you very much.